A trauma patient arrives at the emergency department, restrained, screaming, and actively fighting the emergency medical services crew. This is a 25-year-old male with a 7-centimeter penetrating wound to the right back, actively bleeding with air bubbling through the injury. This dashboard reveals a crashing patient, heart rate 160, oxygen critically low at 88%, and blood pressure unreadable due to violent movement. Classified as +4 on the Richmond Agitation Sedation Scale, he is a direct danger to staff, actively rejecting life-saving procedures. Behavior like this often prompts an immediate focus on restraint. But in penetrating trauma, violent refusal of care is an acute diagnostic finding. This extreme agitation is actually a symptom of severe tissue hypoxia and shock, masking an ongoing physiological collapse. This clinical reality forces an immediate collision of obligations. The physician must treat life threats, but the patient holds the right to refuse care. Hesitating in this high-acuity environment carries severe medico-legal and physical risks. The longer the medical team waits to establish consent, the closer the patient moves toward irreversible shock. Blanket psychiatric diagnoses do not determine if a patient can decline care. Decision-making capacity is dynamic. It applies only to a specific medical decision, under a specific set of circumstances, at a single point in time. To legally and ethically override a patient's refusal of high-risk medical interventions, the physician must document a rigorous standard of proof showing the patient cannot make that decision. Resolving this ethical paralysis is the required first step. No chemical sedation or physical restraint can begin until the physician establishes a defensible legal mandate to intervene. This diagram outlines the Curves mnemonic, a rapid, legally defensible clinical algorithm used by emergency physicians to evaluate capacity. Applying this to our anchor case, we start with choose and communicate. The patient is clearly communicating his choice. He wants to leave the hospital. However, he fails the next two criteria: understand and reason. He cannot grasp his abnormal vitals or the large open wound on his back, and he cannot provide a rational explanation for his choice. Because he cannot demonstrate understanding or reasoning, the clinical assessment proves he lacks intact decision-making capacity. He arrived alone, meaning there is no immediate surrogate decision-maker available. Given the active life threat, the legal standard shifts entirely to implied or emergency consent. By executing the Curves framework, the emergency physician explicitly satisfies their ethical obligations. They are now cleared to seize control of the patient and begin treatment. With legal authority established, the logistics of taking physical control take priority. The medical team has to secure a violent, tachycardic trauma patient safely. This linear progression outlines the 5-step management spectrum for agitated trauma. The severity of the patient's presentation dictates where you start. For a hypoxic +4 agitated patient, verbal de-escalation and trauma-informed care are neurologically impossible to apply. The immediate response is to initiate physical restraints, which are governed by a strict clinical rule. They must never be used as a standalone solution. Strapping a struggling tachycardic patient to a bed forces them to fight against the restraints. This rapidly drives up oxygen consumption and accelerates their physical decompensation, a direct violation of the ethical principle of non-maleficence. Physical restraints are strictly a mechanical bridge. They exist solely for the brief moments required to protect the staff while administering chemical sedation. The first step in achieving chemical control is ruling out acute pain as the primary driver of the agitation. Providers often use rapid-onset analgesics like intranasal fentanyl to quickly address pain without severe hemodynamic side effects. If the patient remains combative, the team is dealing with true hyperactive delirium. Historically, the clinical instinct has been to rely on a single-agent sedative, typically a benzodiazepine, like lorazepam. In extreme trauma, monotherapy frequently fails. Relying on a single medication leads to delayed sedation times and dangerous cycles of repeat dosing while the patient continues to struggle. This molecular model illustrates the American College of Emergency Physicians' recommendation for rapid sedation, utilizing combination therapy to hit multiple receptor pathways at once. To secure our anchor case, the team protocolizes 10 milligrams of intramuscular droperidol combined with 5 milligrams of intramuscular midazolam. For extreme presentations where immediate procedural control is required, physicians can also pivot to subdissociative or intramuscular ketamine. Synergistic pharmacotherapy rapidly collapses the +4 hyperactive state. The patient stops fighting, opening the window for actual trauma care. As the combination sedatives take effect, the physical environment of the trauma base shifts. The screaming stops, the restraints go slack, and the patient lies still. But this compliance introduces a hidden physiological danger. Agitated trauma patients face a high risk of cardiovascular collapse immediately following sedation. The violent struggling was driving a massive sympathetic response, artificially propping up the patient's blood pressure. When sedation shuts down that sympathetic drive, the true underlying hemodynamic reality of the hemorrhage is unmasked. Securing the patient's behavior simply opens the window to address the physiological collapse that was driving the agitation in the first place. Returning to our anchor case, the physician can finally execute the primary trauma survey that was impossible upon arrival. A rapid bedside EFAST ultrasound immediately identifies a critical defect, an absolute absence of lung sliding on the right side. The extreme agitation was masking a developing tension pneumothorax. The team quickly places a right tube thoracostomy, releasing the trapped air and restoring lung function. With the airway secured, the focus shifts to systemic circulation. The massive transfusion protocol is initiated to replace lost blood volume, and the patient is rushed to the operating room. Mastering the legal framework for consent, bundling physical restraints with chemical sedation, and anticipating cardiovascular collapse allows emergency providers to navigate extreme agitation, stabilize the underlying trauma, and save lives.